Thank you very much. And first of all, my sincere thanks to SCP Forum and Shaikat for sharing the dais with you. And my talk will be on the anesthesia management for renal transplant. I do not have any conflict of interest, and this talk is based on mostly on the evidence and experience based. So why I am speaking on this topic? Number one, because the renal transplant surgery has become a very common, and most of the corporate hospitals are doing. Any hospital which have the nephrology, ICU backup, license for the transplant, they can take it up. We started the transplant in 2005. Shaikat, myself, is well equally like for my, as if both of us are equally involved in the transplant program in Apollo Hospital. And so, and then we formulate the team of the nephrology, the surgeon, and the anesthesia department. And till now, I think since inception, we have done around 1,500 good outcome transplant in our institute. So, I mean, why then we take the patient for transplant? So, there is a good clear-cut evidence that all the patients who are end-stage renal disease, that means the GFR is now less than 15% and they cannot have any excretory function, they are all potential for the transplant candidates. And despite that there is a alternative of dialysis, still the transplant is considered because it is, it changed the quality of the life and the survival benefit is higher than the dialysis. The patients who remain on dialysis, the mortality is 70% almost, and that is due to the specifically due to the cardiovascular events. So it has got a tremendous advantage over dialysis, including cost and the quality of life and the repeated hospitalization. So the transplant is always considered in most of the patients, and those criteria has been extended on the recipient also. So there are few contraindications, which is actually nephrology's domain, like active cancer, metastatic cancers, infections, and the comorbidities which are expectant life expectancy is less than the benefit of the transplant. Those candidates, we do not take it for them. The graft survival is very good, like 1 year's graft survival is 98% and 5-year survival is 83%. So there is a good reason that every patient, end-stage renal disease patient, should get a chance for the transplant. This slide just to show you, on the left-hand side, this is the reducing GFR from stage 1 to stage 5, and on this side there is albuminuria. So both of these are the indications, and the grading of the end-stage renal disease is done by this. And you see, as this the GFR goes down and the proteinuria increases, the green zone becoming this yellow, and within the stage 3 it becomes orange, and the red, that means the chance of death is very, very high. Now coming to the systematic effects of the end-stage renal disease, and you can see this slide that you take any organ and the effect of the renal dysfunction will affect that system and the organ, because the pathophysiology of the disease is as such that it affects everything. It affects the microvasculature, it has the role in inflammation, it has the excretion difficulties and the toxin accumulation. So right from the skin to the toe, that is what we say. And I remember one of the statement of Dr. Mani, who is the renowned nephrologist of India. I had opportunity once to hear him, and he said, if he's a Padma Bhushan, by the way, he said that if you find a patient with a vague symptom and vague complaints, and you can't think anything of else, just do a urea creatinine. So it is like that. So any system, you take any system and you will have the disease, right from anemia to the cardiovascular, respiratory, neurological, GI, everything, liver.